Hello, I'm Larry Levitt from KFF. Welcome to the latest episode of the Health Wonk Shot. Roughly once a month, we dive into timely and complex health policy topics with experts from a variety of perspectives. One of the truisms in health policy used to be that medical care prices grow faster than the cost of everything else, eating up budgets for households, employers, and the government. Yet recently, as inflation accelerated in the rest of the economy, healthcare prices lagged. That may not last forever, though. Meanwhile, the president recently signed the Inflation Reduction Act, a momentous measure that addresses drug prices and health insurance premiums for Affordable Care Act plans, but not the cost of healthcare more broadly. We're joined today by an impressive group of experts to sort this all out. Cynthia Cox is a vice president at KFF and director of our program on the ACA. Corey Ryan is a senior analyst of health economics and policy at Altarum. And Susie Desai is senior director and sector lead for the U.S. not-for-profit healthcare group at S&P Global Ratings. If you have questions, submit them at any time through the Q&A button in Zoom. We'll get to as many of them as we can. Also note that this session is being recorded and an archived version should be available later today. It's also being broadcast live on the C-SPAN Now app. Corey, let me start with you. Measuring healthcare inflation is not actually quite as easy as it sounds. There's the medical CPI, the PPI, the GDP deflator. Give us a very quick explanation of what these measures are and what they do and don't tell us.
What these measures are doing, and you're talking about measures produced by the Bureau of Labor Statistics in their monthly survey of prices across the economy, is trying to measure the actual transaction prices that are occurring for medical care products and services. And so when we say transaction prices, we're including all the costs included in the price paid and reimbursement for different types of medical care. And so that's looking at the combination of the amount paid by the insurer, whether it's coming from Medicare, Medicaid, or a private insurance entity, and the out-of-pocket costs that are paid by the consumer. And what these price indexes are trying to do is look at the relative costs of different Medicare medical services over time, while controlling for the market basket or mix of different types of services that are being provided across the different categories of care. And so what BLS tracks for us includes a series of price indexes across different settings of care. So among hospital settings for physician and clinical services and different types of goods, including durable and non-durable products. And what they're attempting to do is show relative to other goods in the economy how overall prices are changing. And what this does for us, with a few caveats, is gives us perspective on how expensive it is to provide medical care in this country and what we're paying for those overall prices. Now, what's important to consider is that who bears those costs varies across the different insurers. And importantly, how those trends are changing over time, as you mentioned, is very dependent on broader kind of economic trends. And I'm sure we'll get into that some of today, both historically and what we're seeing in recent history since the COVID-19 pandemic.
Yeah, well, so speaking of recent history, so as I mentioned in my intro, prices in healthcare have been lagging what we've seen as historic inflation in the rest of the economy. Why do you think that lag has been happening when, for many, many years, we saw healthcare prices rising faster than inflation? And are we seeing signs that it may be changing a little bit?
Yeah, so to just add a little bit of detail to your comment of healthcare prices have typically risen faster than the rest of the economy. What we've seen is that has typically occurred in the series of kind of economic cycles that we see. Healthcare prices tend to rise faster when the economy is in somewhat of a downturn or a recessionary period, because what happens is economy-wide prices will fall, but healthcare prices will kind of maintain or even increase a little bit over those recessionary periods. And so that's how you've ended up over time with healthcare prices rising a lot faster than economy-wide prices. Up until and even at the start of the COVID-19 pandemic, when you saw that kind of very short recession that we had, about a 1 or 2 month recession, depending on how it's measured as a result of the pandemic, healthcare prices initially jumped up, and it was primarily actually due to a jump in public prices, Medicare and Medicaid temporarily bumping up reimbursement for particular services and in particular settings to help compensate for the pandemic. And then as the kind of COVID-19 initial recession period waned off, you saw those public prices come back down, private prices come up a little bit, but things had generally leveled off. And then beginning in the summer of 2021, we've seen this rapid period of economy-wide inflation driven by a variety of factors, including increased labor costs across the entire economy and supply chain disruptions and energy disruptions that we've seen. But healthcare prices have yet to follow suit. And so generally what we are seeing right now is that this lag is appearing And we believe this lag in healthcare inflation is occurring due to the fact that a lot of the payments are set prospectively. So on the government side, Medicare and Medicaid are setting rates for the future year based on what they predict the inflationary pressures and cost pressures are going to be. So they predicted for 2021 and 2022 that those cost pressures would not be as extreme as they ended up being as a result of economy-wide inflation and cost pressures. On the private side, those prices are set as a result of negotiations. And so those negotiations, again, are prospectively setting rates. Now, sometimes those contracts can have space for a little bit of wiggle room and growth over time, but a lot of times those rates are, again, set in advance. And so that is why from a prospective period, this very kind of unexpected and sharp increase in the 2021-2022 period for economy-wide costs has not yet been reflected in healthcare prices because of a lot of those kind of pre-existing settings that have been put in place.
So, Susie, let me bring in you in. And Corey talked about the cost pressures. With the Inflation Reduction Act, we've talked a lot about drug prices. In fact, as a nation, we spend much more on hospital care than we do on drugs. So what are you seeing in the hospital sector right now? What kind of price increases are hospitals seeking? As Corey said, those tend to happen on an annual basis. What are they looking for in terms of price hikes?
Yeah, so obviously most people know that the hospitals are under a lot of pressure on the cost side with the labor pressures, and we'll probably talk a little bit more about that. But in terms of the price increases, and as Corey mentioned, it is a complicated mix between the negotiations that happen. And many times these are multi-year contracts. So sometimes you're not looking for rate increases even this year for some of your payers because the contracts have been set for 3 to 5 years. They may try to open those up, but that doesn't always work. So I think maybe the main takeaway is it's going to be a little bit of a mixed bag in terms of what they would be asking for and what they may be getting. So and it's in terms of price, historically it's been right around that inflationary kind of rate, about 2% kind of rate increases, and that varies depending on an organization and who they are and what the markets they serve. So that's just a very general thing because it's very complicated, as everyone knows, in terms of those structures. With the costs that they're seeing, I think they know that it's probably not going to be as much as the cost rises, as much as the costs have been increasing, but certainly trying to close the gap in terms of where they can get some edge. And like I said, it's going to vary by the payer market. It's going to vary by their position in the market. And so it's definitely going to be mixed going forward, I think, with what they're going to see. And it's really at the end of the day what the employers can also bear, right? In terms of kind of how much can the insurers push on to the employers. And if they're struggling too from an inflationary perspective, I think it's just going to be a very challenging time.
So Susie, you mentioned the cost pressures, the input costs for hospitals, and labor is certainly a big piece of that. And there's upward pressure on wages now with economy-wide inflation, in healthcare as well as in other occupations. Can you get a little more specific about what those wage pressures are? We've heard a lot about traveling nurses pushing up wages for nurses. What are hospitals seeing in terms of those input costs?
Yeah, so obviously the salary and wages and the agency are the biggest conversation that we have with the credits and the organizations that we talk to. Salary and wages, it's anywhere kind of 8 to 10%, could be higher, could be a little bit lower, but kind of in that range is what we're seeing just overall, that expense bucket. That doesn't include generally the agency costs, which have been significantly higher for some in the country. It's starting to come down a bit, but it's not nearly what it was 2019 level. So sometimes, 5 to 10 times what they were spending on agency. Because in the past, there's always been a little bit of agency usage to fill in some gaps, but to that level, it's still fairly high. And it is coming down from the first quarter numbers, both in use and rates, but nothing like, still hasn't reached 2019 levels. I think the other place that we're seeing inflationary pressures are on the supply side. That's a little bit more muted because, like the payer contracts, those are sometimes negotiated up front. So for the year, they sort of had that amount settled. It's now going into 2023 as those get renegotiated in those contracts, or if there were shortages and they had to go out of contract, which did happen over the year. But that's where we're going to start seeing, potentially some increased pressure on the supply side as well. And then the last thing, not for everyone, but depending on if you're in projects, construction costs are also going up. So that's also a factor for hospitals, which again, it's a capital intensive space. So those are the ones we're watching.
And Susie, you talked about agency use, travel nurse use coming down. What do you have a sense of what share of nurses are now through agencies?
That again, it really depends provider by provider. There have been some that have used alternative mechanisms, maybe to not have as much agency by using their own premium pay or creating their own pools. So it was already maybe not as high. So it's hard to kind of pinpoint a number because it really does depend on places. But so I don't know if I have a number off the top.
Got it. Cynthia, let me bring you in. And Susie talked about, hospitals seeking price increases, and how successful they are may depend on how much employers and insurers push back on that. Insurers obviously need to anticipate what provider price increases are going to be, because they don't want to be caught flat-footed and lose money. We're seeing kind of insurers set those premiums right now. What are we seeing in terms of premium increases for next year?
Yeah, so each year health insurers submit these kind of rate filings to state regulators that are hundreds of pages long and detail all of the math and assumptions that are going into their premiums for the coming year. And so we've reviewed dozens and dozens of these filings, particularly in the individual health insurance market. Now, this is a relatively small group of people compared to how many people get coverage through employers. But the filings that are submitted in the individual market are really detailed and publicly available. And also when it comes to things like inflation, it's probably pretty indicative of what insurers are experiencing in the employer market as well. And so what we found is that in the insurers that we reviewed, which was 75 health insurance companies from a variety of states, they were raising their rates by about 10% going into next year, which is much higher than we've seen in the last few years in this market, because premiums had been pretty flat the last few years. And the bulk of that, we're looking for all kinds of different causes, everything from the pandemic or policy changes to inflation and utilization. But the bulk of what we're seeing is what's called medical trend, which includes both inflation and utilization, rising prices and rising utilization. And so insurers are expecting healthcare prices to continue to rise, and that's part of what's driving premiums higher next year.
And how, certainly in the employer market, employers and employees are going to pay those higher premiums, and there may be some pushback there. What are the dynamics in the individual market? How much of this premium increase will enrollees in the ACA marketplace actually face?
And so most people in the ACA marketplaces are subsidized by federal subsidies that essentially cap what they have to pay at a certain percent of their income. So if you're on the lower end of the income spectrum, you might pay nothing for a mid-range plan. And then if you're on the upper end of the income spectrum, you would pay maybe 8.5% of your income on a premium. But anything that's above that is paid by the subsidy. So this market, the subsidies that exist in the individual market really shelter people from paying these price hikes for the most part. But it's one caveat there is that the enrollee might have to be willing to shop around and switch plans in order to take full advantage of that subsidy.
Corey, let me come back to you. You mentioned earlier some potentially different trends for private payers and public payers like Medicare and Medicaid. Get a little more specific if you can. What are we seeing in terms of those diverging trends, and how does that compare to what we've seen kind of over the long term?
Yeah, so over the history, typically prices paid by private insurance for both hospital and physician care have increased more rapidly than the public payers have. And that's a trend that we're expecting to continue through the rest of 2022 and into 2023. When we look at what Medicare is proposing for the increased rates for calendar year 2023, we're talking about increases somewhere between 2.5% and 4%, depending on which of the kind of hospital or physician prices have been proposed to increase. And actually, physician prices are on the low end of that scale as far as what Medicare is going to reimburse. Prices are set through these kind of more complex negotiation processes, and we are just starting to see a little bit of an inflection in increasing private prices, first among hospitals, and I'm expecting that will continue among physician and other settings of care. as well. And I think that is coming primarily from the fact that those negotiations really are favoring the providers right now. They are seeing increased cost pressures, and so they have a greater incentive to negotiate for those higher price increases. And insurers are still coming off a period when utilization has been somewhat suppressed as a result of the COVID-19 pandemic. It is coming back. I think an ongoing question is how much of a rebound there will be in that utilization. There was a big question, as we were coming into 2021, 2022, if utilization would kind of reset to the level that it was at prior to the pandemic, leaving a bunch of care that was foregone in that period, or if there would be really a bump up and a catch-up period where a lot of folks would go back to get care that they missed during the pandemic. I think as far as that's impacting overall costs and overall utilization, what I think we're seeing is more just kind of a return to the level of care that was being received before, and not necessarily an initial, a much higher rate of utilization over the coming period. And so what that's going to result in is providers are going to have to negotiate higher prices in order to cover these increasing costs that we've been talking about. So I expect private prices to lead in 2023, and then we'll see what happens with the Medicare and Medicaid rates as those get set for future years.
So we might even see a kind of increasing divergence between private and public prices. I mean, for example, in hospitals, our research has shown, private prices are roughly double in private insurance what they are in Medicare, and we could see that gap grow even further potentially.
Yes, yeah, I think that's definitely what we expect, and that's a very good point to bring up. Is kind of the difference in talking about price growth, which is often what we're reporting on when we're talking about changes month over month or year over year, versus price levels. And yes, private prices continue, the level of private prices, double or even greater depending on the markets and the providers that you're talking about relative to public prices.
And I think one thing I agree on there's probably going to be some divergence, but one thing that we have heard from the state side and our counterparts that follow the states is from a Medicaid perspective, at least for now, and it has been stable. So, because they got a lot of ARPA funds. So in terms of price decreases or any of those kinds of things that could affect hospitals, at least for now, but we're, potentially if we're heading into if we get into a recession, a real recession, that could change things. But at least for now, it's been at least stable, which is good for Medicaid.
And Susie, do you have a sense, with the potential end of the public health emergency, how that might affect hospitals? Certainly in Medicaid, we've seen a tremendous increase in Medicaid enrollment with the continuous coverage requirement that would end with the public health emergency. We've estimated, between 5 and 14 million people could lose Medicaid coverage. How will that play out in the hospital sector?
Yeah, and I think a lot of that depends. I think as those folks roll off, that's certainly a negative for the providers that we rate, because they are coming in now potentially without insurance. But the one good news with the act that just passed, some of those expanded subsidies, to the extent that they move on to some of those the individual exchanges, that would maybe limit the negative impact from that. But it's a big question, right, to get some of those folks onto that. And also in terms of the public health emergency, there's been a little bit of additional Medicaid rates coming through as well, so that's been favorable. So those will also come down. So that's another pressure point for hospitals kind of going into the next year, depending on, again, when that emergency gets lifted.
And in general, what are you seeing in terms of hospital margins, compared to, let's say, a couple years ago?
Yeah, so we're watching these quarterlies. We do get quarterlies from most of our providers. So we're obviously the first quarter was tough for most places. There's a few that eked out profits, but it's far and few. I would say the second quarter was, for some, a little bit better, but still very challenging. So I would say on an operating margin perspective, which is kind of your core operations for a hospital of, really just sort of the services you provide and the costs related to that, it's mostly been negative in terms of margin. So it could be anywhere from kind of break even, negative, to like as high as I've seen, negative 12, 13%. So it really depends on the market again and who you are. And we're trying to get a handle we're trying to get a sense of if there's any sort of underlying trends that we can tell there. But it's been tough. Overall cash flow, still positive, but it's definitely much, much lower than it was in prior years, through these first 6 months anyway of the calendar year.
And Susie, let me stay with you. We've had a couple questions about the role of investors, the role of profits. in healthcare. You cover the nonprofit sector. Do you and you may or may not be able to speculate on this, but do you think there are any differences in how these kind of pricing pressure will play out in the nonprofit hospital sector versus the investor-owned hospital sector?
I'm not sure I can comment too much on what will happen on the for-profit side relative to the non-for-profit side, because I think there's just different, the for-profits, they tend to be in different markets than our overall population of non-for-profit hospitals. They tend to be in certain more, they may have hospitals in other areas, but like they have a lot in Florida and Texas and sort of in some of the growing states, whereas our providers are everywhere, right? It's wherever the populations are. So I don't know if I can comment too much in terms of how much different pricing pressure there may be for them versus us. But I see the costs and I see what they're experiencing on our side. So that's kind of where we go to, like where, when we ask providers, where's the relief? And so you can cut costs, but it's hard when 50% is labor. And if that's the main area of the pressure point. But, looking at other avenues of what are the strategies outside of rate increases, is a conversation we have with our providers.
Cynthia, we had a question about the No Surprises Act and how that might play into prices. Talk a little bit about what the No Surprises Act does and how that might affect prices on the provider side.
Sure. So what the No Surprises Act does is it essentially holds consumers harmless for surprise bills. So surprise bills have been something that a fair number of people in the private insurance market had experienced, where they might go to a hospital and that hospital is in their network, but then they get seen by a provider who's out of their network. And then they get this surprise balance bill from their provider that is beyond what their insurance would cover. So the No Surprises Act is holding consumers harmless and saying, the enrollee does not have to pay that. And it's kind of between the insurer and the provider then to figure out, how much that provider is going to get paid. And there's these, independent dispute resolution systems to kind of navigate that process. But we looked into this when we were looking through all of these insurer rate filings to see, well, what are insurers saying about how this is going to change their costs? There have been some speculation about whether this was going to drive premiums up or down, and what we saw is that really insurers weren't mentioning this much in their filings. Of the couple of insurers that did mention it, they basically said it was having no effect on how much their costs were going to add up to. So at least for now, and this is actually the second year we've seen that happen. So at least for now, it doesn't seem to be having much of an overall effect from an insurer's perspective.
I mean, maybe some effect on the margins in terms of bringing down prices for, particularly emergency medicine practices or anesthesiology practices that are sort of outside the norms.
Right. Yeah. There will be certain providers that are greatly affected by this, but on average, at least, it doesn't seem to be the case that insurers are expecting it to drive costs overall in either direction.
Corey, we had a couple questions about the Inflation Reduction Act. Certainly a reasonable topic, given that we're talking about healthcare inflation. As I mentioned in my intro, that is primarily targeted at ACA premiums, which Cynthia talked about, as well as drug prices. Part of the Inflation Reduction Act does require rebates for paid by drug manufacturers if they increase effectively list prices faster than inflation. Those rebates start next year. Talk a little bit about what you're seeing in the inflation data in terms of drug prices versus prices for hospital care, physician care, and if you have thoughts about how you expect the inflation rebates to play out.
Sure. Yeah. So what we track as far as prescription drug prices is primarily an index of retail prescription drug prices. So drugs that are administered in a hospital or as a part of hospital care, which we would think of on the Medicare side as being like Part B drugs, are a little bit more hidden to us. But when we're talking about retail prescription drugs, what we've seen is that there was a period between about 2015 and 2017 where we had, I would say, above average period of prescription drug price growth in the retail setting. And then a period between 2018 and through 2020 and into the pandemic, when we had below average prescription drug price growth and actually slightly negative prescription drug price growth. I think our primary hypothesis for why that was happening is that there was a somewhat smaller portion of, again, these retail prescription drugs that were new branded drugs. And so there was an increasing shift of more drugs going to generic and that overall index falling slightly over time, because a lot of the expensive drugs in recent years have been on the hospital administered side in that Part B bucket and not in what we would consider a retail prescription drug portion. There's also a caveat there in our retail prescription drugs and how rebates are accounted for within the private market. There's some complexities there that impact that price index as well. And so what we have seen is that prescription drug price growth in the recent period in 2021 and 2022 has come back to about average with the rest of healthcare price inflation. So somewhere between 2.5% and 3% year over year. And that's something we're probably expecting to continue into the future. As far as the impact of the Inflation Reduction Act, I think those rebates, which phase in slowly over time, I think in the near term, we're not going to see very large impacts on prescription drug price growth as a result of that, given the limited number of drugs and also the ability of manufacturers to adjust and compensate for those, in the way that they launch at list prices as well. So there's going to be a kind of variety of factors going into the way that impacts overall inflation. But I expect that the largest components of the Inflation Reduction Act are going to be benefits directly to consumers as a result of what Cynthia said, as ensuring that those premium supports maintain a place on the marketplace, and probably on the margin, some small reductions in prescription drug price growth. But I think it will remain positive and near where it's been in the history going forward based on what we're seeing.
And Susie, we had some questions about how you kind of measure the financial health of hospitals. And you talked some about margins, some negative margins recently, also cash flow. Without giving us a long accounting lesson, give us a sense of how you look at the financial health of hospitals and what some of those different measures tell us.
Yeah, so the big ones for us are cash flow, and we look at margins, but really kind of cash flow, because that's really what's going to support both the capital initiatives, the growth, if there's need for building out, outpatient space or whatever it might be, the cash flow is the first place that's going to fund all that. And it's going to fund, and so that's a key measurement. It also tells us, if they're able for us, because we are a rating agency, also how much they can cover their debt service that they're paying sometimes when they borrow for these bigger projects. So the cash flow indicators are a big component of what we're looking at, and it tells us again how much they're able to generate and how from the revenues they're getting. How much of that can they fund back into the system? It also goes into strategic initiatives, as some of these technology things are very expensive. They're not necessarily capital, but they're operating, goes to fund all of those kinds of things. So that's one layer. The other thing that we look at on our non-for-profit hospital side is the balance sheet side of the equation, in terms of how much in reserves and cash do they have. And obviously back in 2020, when everything stopped, it kind of is. We have one metric called days cash on hand, which is basically if your revenues stop, like how long can you basically keep going with the expense base that you have. And so that's another key component. And what that tells us is just how much financial flexibility there is to manage when you do have some crunches. And again, that's for us because we are also looking at credit ratings. But the other piece of that, those balances also provide investment income, which helps to, again, go back into supporting the various strategic and capital initiatives. So I would say that the balance sheet gives us a sense of the financial flexibility, how much cash is there. If they do need to do a big project, do they have the funds or do they need to borrow? And we also look at how leveraged they are and how much debt they have outstanding, because that'll put pressure both on the cash flow, but also their ability to borrow in the future. So a few different components, but cash flow, overall financial flexibility, how much leverage they have, how much cash they have if they need to spend on certain projects, if their cash flow isn't as strong. Those are probably the key areas that we're looking at.
And Susie, you mentioned ratings. Obviously, that is a core of what you do. How have there been any kind of systematic changes in ratings in the hospital sector?
Yeah, so coming into 2022, the short answer is there has not. We haven't had a lot of downgrades or upgrades. They're about equal, and I would say nominally they're not that high. But what has happened is coming into 2022, there was a lot of, the investment markets have been pretty strong. So those balance sheets, even though there was some fluctuations maybe on the operating cash flow side, the balance sheets were holding that stability on the credit rating. Because again, the credit rating is the ability and willingness to pay your debt back over the next 30 years. And that's kind of what we're trying to assess, or to the best that we can. So coming into this year, and a lot of the funding from the stimulus funds really helped to support hospitals coming into this year. So a couple of key things and that sort of put the organizations in a relatively good spot as they were coming into this year, which was obviously we saw was going to be pretty challenging, maybe a little bit more challenging than what we anticipated from the labor side.
Susie, let me stay with you for a second. We had a couple questions about how all of this may impact kind of market structure, consolidation in the hospital sector, the drive towards shared risk arrangements, ACOs, accountable care organizations. Are you seeing any differences in trends? I mean, there was a rush to consolidate, a rush to enter into these ACO arrangements. Are you seeing any of that cooling?
I think what we're seeing now is it feels like a lot of, especially ones that are in a very pressured situation with their labor situation, is kind of need to kind of refocus on that and get the labor piece under control. That's not to say that the other strategic initiatives like building out ACOs or working on different kinds of strategies to reduce expense, improve the cost of care, or improve the care delivery system, and all of those things that we've been hearing about are on the, are necessarily completely on the back burner, but there is a lot of focus on trying to get things in order, or get things into a manageable situation from a labor perspective. That said, I think all those other initiatives, if they had been making investments already in those areas, I think they're probably in a little bit better position to keep building on that. If you're trying to do something new, it probably is a little bit harder. And as we look at M&A, we've seen some big mergers kind of happen over the last year or so. Those tend to be very strategic in nature. Those are also the ones that I'm thinking of. They're stronger organizations from a credit rating perspective, so just have some more flexibility there. But those have been very strategic in terms of not about like a weaker and a stronger getting together, but as two stronger systems that maybe want to push value a little bit further, and some of those initiatives coming together. I think we'll see what happens in terms of going forward. There is more scrutiny also on those mergers, in terms of, and some have been denied in the last 6 to 9 months. So we're not hearing a flurry of interest, but I think if there are smaller organizations that are very pressured, they may be looking for partners. And I think we'll continue, once things maybe settle, we'll continue to see some focus on partnerships and sort of larger, maybe strategic initiatives as we move towards, there seems to be still a push to move towards value-based care.
Corey, so we've been talking a lot about healthcare inflation and how that's driving price increases and premium increases. We also had a question about the reverse, how general economy-wide inflation may be driving particularly Medicare rate increases, and how inflation and wages figure into those rate increases. And you talked a little bit about this earlier, but if you could talk a little bit about the lag in that, and what's the timing of when we might see this recent surge in economy-wide inflation factoring into Medicare rate increases?
Yeah, so when you're talking about economy-wide inflation, I think the biggest factor there is how those cost inputs to providing medical care and healthcare products and services impacts the overall prices that are then negotiated for the care that is received. And as Susie mentioned, labor is often the biggest portion of either a hospital or a physician office's cost. And health labor costs have been increasing at a faster rate than even economy-wide labor costs, which have already been at kind of an accelerated rate. And we expect those pressures to continue, and the demand for healthcare services is only going to continue as we see an aging population and an expected increased demand for care over time. Specific to the Medicare point that you're making, the way that those prices are set is prospective, and it's set based on recommendations from the Medicare Payment Advisory Committee. And what their intent is to cover, from a hospital perspective or from a physician perspective, their total average costs of providing care. So that includes the marginal cost of providing care, and then the fixed costs that it takes to keep their facilities open as well. And so they are doing the best to understand what the underlying cost pressures are and match their future rates going forward with what they think those costs are going to be. A couple of folks, I think, in the chat and the questions have brought up the fact of, well, they kind of missed the boat in 2022 a little bit because we weren't expecting these increased cost pressures to occur. As far as I'm aware, Medicare is not going to kind of catch up for that. So there may be a little bit of a lag in the period that happened here, but we expect that they will be increasing rates going into 2023, attempting to again match what those future cost growth changes are going to be. And then a great point by Susie as well here in there's going to be increasing pressure to kind of change the way that we pay for healthcare as well. So it's not just what the price levels are going to be, but trying to transition from this very historical legacy system of paying for every service that we do in a fee-for-service way, and moving towards paying for value and trying to bring these payments together in a way that better align the incentives to improve patient outcomes and in patient health, with the overall cost of providing care in the first place.
So I want to turn to a question we got about back to the Inflation Reduction Act and what effect the drug pricing provisions might have on private sector prices for drugs, since those drug pricing provisions are primarily focused on Medicare. And I'll maybe take a first crack at that as the moderator, and then see if you all want to add anything. So there are really two components to the Inflation Reduction Act's approach to drug pricing. One is allowing the federal government for the first time to negotiate prices in Medicare for certain drugs, and that ramps up over time. The second, as we talked about earlier, is requiring drug makers to pay rebates to the federal government if list prices rise faster than inflation. And those rebates are calculated based on drug prescription use in Medicare. So on the rebate side, there I think is some potential positive spillover to the growth in private sector drug prices over time. For drugs that have a mixture of use in Medicare and private insurance, manufacturers may tend to roll back some of their expected price hikes over time, knowing they would have to pay a rebate to the federal government based on prescription use in Medicare. I think the more difficult and controversial topic is drug price negotiation in Medicare and whether that might result in cost shifting to private insurance. And there have been multiple points of view on that. One, that drug manufacturers are profit maximizing. If they could charge higher prices in private insurance, they'd already be doing that. So we're not likely to see cost shifting. Some other arguments that the drug makers tend to have sort of a revenue target for new drugs, and if they're getting less from Medicare, they may try to get more from private insurance. And these are drugs that are sole source drugs without a lot of competition, so they may be able to do that. So I think there's a lot of uncertainty around what effect these drug pricing measures might have on private insurance. But I didn't know if Corey or others want to jump in there.
Yeah, I think great thoughts there, Larry. I think I generally also fall on the side that the cost shifting hypothesis has generally been disproven in healthcare, both on the services side and also on the product side as well. I think these manufacturers are going to profit maximize, and if they lose a little bit of revenue on the Medicare side, they're likely doing everything they can to already maximize their profits on the private sector side. So I wouldn't think there would be a gigantic kind of rebound impact there, but I could be wrong, and I think I expect much more research in that space going forward as some of these new rules are implemented to track some of that.
That's not a question. We talked a lot about labor costs on the hospital side, but of course, health insurance costs affect compensation of workers who are getting insurance from their employers as well. Cynthia, if we see a rise in insurance premiums, what effect is that likely to have on compensation, on cost shifting to workers?
Yeah, I mean, that's exactly right. So, I mean, we still don't know. We will soon know. I guess we have a survey going out now to employers to find out whether they are expecting premiums to rise going into next year. But, so we still don't know whether these inflationary trends that we're seeing are going to flow into the health sector and then flow into higher premiums, at least for the coming year. Maybe it will happen eventually too. But to the extent that that does happen, then employers and employees will be, hit by those higher premiums. And often what we've seen is that employers are thinking about compensation in a total package. It's not just their salaries that they're paying to their employees, but also what they're spending on their health benefits. And so if what we've seen in the past is that healthcare costs have risen faster than wages, and that rising premiums are kind of coming at the expense of wages and salaries to employees.
Yeah, and if I can just jump in there, another trend that we've seen from the employer side has been that employers have tried to manage their medical cost trend by shifting some of the costs back onto the employee by rising their deductibles and rising their cost sharing. The extent to which they can continue to do that, I think, is an open question. There was a big trend of doing that over maybe the last 5 years and certainly over the last decade, as we've seen average deductibles go up significantly. So there may be more pressure as premiums go up and more pressure on wages as well from the employee perspective and what they're seeing in the group marketplace.
Yeah,
and I know.
Oh, sorry. Go ahead.
I was just going to add on the deductible side, because we've seen that too, that shift to higher deductible plans, and that's it's something that we'll continue to watch because as that shifts more on the patient, then it becomes potentially an area of pressure for the provider if they're not able to pay that, and it becomes a bad debt expense, and so that's another layer of expenses. So again, something that we're monitoring and watching. Sorry, Cynthia.
Oh, yeah. And I was just going to say, I mean, the other factor here is that, we're at near full employment in the economy overall. And so, that means that employers might be making different calculations when it comes to trying to shift healthcare costs onto employees too, in order to maintain and attract employees.
Corey, I wanted to return to something we started with these kind of different measures of healthcare inflation. The consumer price index, the producer price index, the PPI. Which ones should we be keeping an eye on, or should we be keeping an eye on different ones for different things right now?
Yeah, I think you have to look at the entire kind of suite of metrics that are being produced. They generally will follow each other. Comparing PPI and CPI for similar measures, they have different purposes. The PPI is trying to track the cost and price growth from the supplier perspective, versus the CPI is trying to track it from a household budget perspective. So those factor in kind of the overall indexes in a slightly different way. What you'll see is, from a truly kind of data nerd standpoint, when you go to BLS website, you get more detail on the PPI side. You get some of the by payer measures and some of the other additional kind of by setting measures as well. So that tends to play a little bit of a larger role into some of the conclusions we draw in our work, but taking a look at the entire basket. And one other thing I'll bring up is some novel work that's being done at BLS and BEA as well, and trying to track prices and spending in healthcare from a broader perspective, from more of a disease perspective and a condition perspective, rather than from a setting perspective. And I think that's an interesting space that folks should keep an eye on too, because in some sense, the price of an individual service is not really what we care about in healthcare. We care about how much it costs to keep us healthy and how much it costs to treat disease. And so trying to do a better job of looking at prices in healthcare by using some of these alternative measures, I think is something that's very interesting and really important to consider too.
I think it's good to bring us back to that. And we had a comment from one of the listeners that we've talked a lot about financing and revenue, and healthcare is about health. So it is certainly good to bring it back to what the system is trying to produce. So we're coming to the end of our time, and I wanted to give each of you an opportunity to give us one thing that you'll be watching, or that people should be watching over the coming months when it comes to healthcare prices and inflation. Susie, maybe I'll start with you.
Yeah, I think it's I think the big thing, I know it's talking about pricing, and this goes into that, is sort of where the labor, when we will start to see those labor pressures ease for healthcare, because that's going to play into a lot of the pricing and what the needs are going to be from the hospital provider side. So that's probably the big key thing that we're watching, is when those pressures will ease and what mechanisms they're using over the next year or two to kind of get that back into a more sustainable level.
Corey?
I think the biggest thing I'll be following, as we talked about today, is really the differential in price growth across the different payers. I think the cost pressures among all these payers in providing care is exactly the same. The way that the prices get set are very different, and I think you're going to see a divergence, a further divergence between private and public prices over time, and the way that kind of impacts the overall system is something that's important to track, and then even more important than that, the way that prices impact kind of total healthcare received and total spending, because of course prices are one of the major growth factors in overall healthcare spending, which we haven't talked about as much today, but I think that's very important to keep track of as well.
And Cynthia, I'll give you the last word.
Sure. Well, just one thing that we haven't really talked much about is, we talked about hospitals and physicians and prescription drugs, but nursing homes and community care organizations are also a place to be looking right now. And we're seeing that, employment in that area has fallen and average wages are growing. And so I think that's something to look out for in terms of the future of nursing home and long-term care too.
Yeah, and tragically, we actually just have new numbers out showing that the number of residents in long-term care facilities has declined in part because of the very large number of deaths that we've seen during the COVID pandemic. So I want to thank our panelists for a terrific discussion, and to all of you for joining us. And keep an eye out later today for an archived version of this discussion, and keep an eye out for the next Health Wonk Shop next month. Thanks.